Good morning, everyone, and thank you very much. Welcome, yes, for being here in our second twinning webinar, COMFORTage second twinning webinar. In this session, yes, that is part of our ongoing exchange pathway, yes, towards the COMFORTage twinning activities. The aim, yes, as you know, is to connect pilots and potential adopters, yes, to share experiences, to explore how innovative these good practices that our pilots have been working on can be transferred and adapted across different regional contexts. So today webinar is focused on the organizational transformation needed to implement digital enabled interactive care models. So in order to support older adults at risk of frailty, cognitive decline. Without further ado, yes, I would like to give the floor to Madalena, who will welcome you and guide you through all the session. Madalena, the floor is yours.
Thank you so much, Silvia. So welcome everybody to the second stop of our journey towards the twinnings, the COMFORTage twinning activities. As Silvia already mentioned, this is an activity that is meant to foster and stimulate and support knowledge exchange between the pilot and their good practices that are emerging from the pilots and the reference site as potential adopters, and any other organization from reference site that is willing to transfer, to make an effort and be supported by the RSCN and COMFORTage community to test and adopt the good practices. Our concept of good practices is not referred to the entire effort that is being implemented in the pilots, but we preferred to identify transferable elements that are already available and emerging from the pilots that could be tested and thus allow COMFORTage community to be broadened in a wider ecosystem. And in this effort, we identified three different focus. The first one we attended together. It was carried out with a focus on early identification and risk stratification for frailty in older adults and cognitive impairment and dementia. And this time, instead, we are focusing on dementia and frailty as intended as a composite conditions. So this condition, neither of these two conditions is isolated. Everybody who is familiar with these two conditions knows that often people who present cognitive decline and frailty are also affected by multimorbidity and thus have a very complex health needs. And the availability of digital solutions, innovative approaches is a key element to improve the health outcomes and allow the implementation of integrated care. So this is the perspective we would like to give to this webinar. So without other comments, I've preferred to give the floor to the key role players of COMFORTage, who are the pilot leaders and all the people involved in the implementation of the pilots. It's a big effort. We know that they are being successful in the implementation of these pilots, and we would like to hear from them what are the transferable elements they are making available to the regions. So I would like to invite Konrad Regidak from MUL to introduce Pilot 5, Strategy for Prophylactic Brain Health Among Middle-Aged Adults for Risk of Dementia. Please, Konrad, the floor is yours.
I'm not sure, Madalena, if he has already connected.
So maybe we can just
pass on
Maria.
Yes,
and then
let's pass on to Maria.
Konrad,
That's it.
Okay.
Thank you.
Maria Karangianni from OUT, Pilot 6, Early Identification of Dementia on Patients with Early Signs of Sarcopenia and Frailty. Please, Maria, the floor is yours.
Maria,
maybe you have to...
Hello, I'm sorry, I didn't open my microphone. I'm sorry. One moment to share my screen. Uh, okay, I think you can see my screen.
Yes, not in presentation mode, but
I think now
now,
it is.
perfect. Thank you.
Okay, so we're going to talk about Pilot 6, multimodal prevention for frailty, which is associated for cognitive decline and with wearable monitoring. Some key aspects in our pilot, it is that it is about frailty and cognitive decline prevention. The main aspect it is to prevent cognitive decline and physical frailty for people by using a remote digital intervention. It is a home-based multi-domain digital intervention. The participants can do this in their own space, in their own home, in their own environment, after having a training. Wearable monitoring and IoT data collection. They are also given some smart watches, smart scales, so they can use and wear them in their own home. And that helps us for us to have monitoring of their everyday physical activity, and also having monitoring their weight and how they keep track of their of how they gaining or losing weight. We also give them the cognitive training. This is with a platform, nutritional and physical activity, as we're going to see by an app. And all that it is for remote prevention for older adults. The main target, as we're going to see, it is in the early stages of frailty, which is one of the innovative parts of this study. So, as we're going to see some of the background and problems, it is that frailty is strongly associated with cognitive decline. It is a strong association, and we see that as the body becomes more fragile and we lose strength, and it is easier for the person also not only to have problems with his own health and going more often to the hospital, but also this is associated with other diseases, and also with having the first signs of cognitive decline, and also having problems in coming into dementia. So traditional prevention approaches that is usually being suggested, it is the physical and the cognitive training that these people should have. However, it is something that that the literature shows that the combination, when people have physical, nutritional, and cognitive training, it is the most effective. People with frailty also, they are not so easy to attend somewhere. So uh, the most important it is to have something that they can do in their own home, and they can apply it with their own environment. So this will have a better adherence, and they will have the best result for them. So it is a need for an integrated prevention targeted both cognitive and physical vulnerability of this population, a vulnerable population of the older adults. Also, an element for this study, it is that we want to catch this earlier. We want frail people, but not so frail that they have started losing their functional abilities, but people that are early in the frailty part, so they have started losing some of their ability. They are slower in walking. They have less strength. So we want to see if that can be a prevention measure, or finding the risk factors for that and having to decrease their physical frailty and their cognitive decline. So as you see, this is a need to have a home-based monitoring solution for the older adult. The main goal is to improve the cognitive and frailty outcomes through the remote and multimodal prevention. So this study, it is a randomized remote home-based intervention. It has clear and appropriate inclusion criteria. We made the criteria clear in order to specify where we want to include in the study. It is multi-component intervention with cognitive, physical, nutritional, and this is also the outcomes that we want to measure. The wearable monitoring and digital health applications that support this data. So it's not only the measurements that we have or the subjective. We have data about their behavioral status, and we follow them for 18 months. And we have follow-ups that can help in these assessments in multiple time points. The targeted population that we have, it is 55 plus with early signs of frailty. Participants classified as pre-frail, as we mentioned before, that they haven't started yet to show losing their functional abilities. The recruitment is through the Sick Cardiology of Hippocrates Hospital and daily care centers. And we also have an additional group, healthy older adults, that we want to compare them with the frail older adults to see also and extract the trajectory of their health and some risk factors. So some core innovative elements of this study, it has to do with a multimodal digital intervention, the remote digital intervention. It is based in the combination of the cognitive training, and we said, and the physical and the nutritional. And this is via Brain HQ, the cognitive training that is with the platform, providing scientifically designed exercises to enhance brain function and cognitive abilities. An app that was developed in our premises in the digital. It is an application with features that has inside with physical activity programs, personalized exercises routines aimed at improving overall fitness and well-being, nutritional guidance that has dietary advice to support healthy eating habits and nutritional balance, and also for them to record, keep a track of what they are eating and what they are consuming. Education on frailty prevention, resources and information to help prevent frailty, prompting long-term health and independence, integrating monitoring. This is with the Fitbit integration and within compatibility. So we said about keeping track of their physical activity, monitoring and analyze weight and body composition. This is a holistic approach to address mobility, cognition, and lifestyle. So the second core innovative element, it is the pre-frail population. It is a remote program. Most of the studies are aiming frail older adults. So here the aim is for the pre-frail that haven't yet lost it's not obvious about their functional loss or their physical. A third element, it is the use of the wearables. We have wearable devices to collect the past behavioral data, continuous monitoring of activity patterns, supports identification of predictive markers of decline, and provides objective data for personalized interventions. So some transferable elements of this study are the home-based digital multimodal prevention program. It's a program that can be simulated in every home with some simple modifications. So it is home-based, it's guided exercise modules, also with the cognitive brain health activities, educational content, with a nutrition and healthy lifestyle. We have the wearable monitoring of behavioral activity patterns. Also, it is the engagement and the adherence strategies. It is easy to have and keep track and regular participant checks and continuous progress monitoring. And of course, it is a holistic frailty cognition prevention framework, easily transferred in different clinical settings with some modifications. So it's something that can start for clinical, like it started in the cardiology, and it can be implemented in other settings, also in clinical settings. And with some modification, it's something that it can be a preventative measure also for other settings of daily care livings that can, or for doctors. So digital multimodal intervention has integrated, as we said, cognitive and physical prevention, the wearable monitoring with objective behavioral data, engagement and adherence strategies, regular participant check-ins, holistic assessment battery. The assessment that we use, it is holistic, it is multifactorial healthy monitoring, and it is standard assessment that can be used in every setting, and it can be used in from many different people. It's something that's very standard. The data that we have, it is a neuropsychological and cognitive assessment data that has to do with memory, attention, executive functioning. The physical and nutritional assessment has as an examples about the hunger, the balance, the strength, also related with the physical frailty. Using standard tests that used in every setting that is set in the bibliography. Clinical and demographical data about medical history, comorbidities, medication, blood exams. Wearable monitoring behavioral data, the Fitbit Smart Scale about the weight, the body composition. We also measure quality of life and mood indicators that has to do with isolation, depression. We want to see how that affects their lives. The technical infrastructure is the Brain HQ for the cognitive training, VM Health, the app, the digital application for the physical activity, nutritional, educational contact, wearable monitoring devices, integration of assessment tools into digital systems. For that, we use the Red Cup platform as part of the COMFORTage project to capture and insert and just all our data that we collect. So here it is a multidisciplinary clinical research team, collaboration between hospital, technical, and supporting digital tools and data captures, participant onboarding and monitoring teams. This is all the organizational model that makes this study possible to be. And here it is the process of the study. The participant is coming in the recruitment through, when we have the first recruitment, the participant that comes from the hospital for some daily care centers, we first check him for the eligibility criteria. So he has a first screening. Then there is a randomization into the groups. An allocation to the appropriate group. So the person that's going to the study group dependently. So then we have the baseline assessment. And for the intervention group, they have a training to have the home-based digital intervention and the monitoring. It is the assessment and the training where they receive the Brain HQ, the app, how to use it, how many times they take specific instructions, and also they receive the smartwatch and the smart scale. From that point after, we have the follow-ups, we have assessments after 6 months, in 12 months, and in 18 months. And finally, some lessons learned. It is in this study that recruitment pace may be affected by seasonal factors, and this is very true about older adults, at least in Greece. We had some big breaks that have to do with Christmas, that have to do with the Easter, it has to do with the summer. So it's not easy to have participants at these time points, and it is very difficult also to have them to do the training or do the assessments. The participant adherence risk in long digital intervention, this is a high risk, and it is very difficult for them to engage them for a long time. And this is something that needs to be paid attention of how close we have to be to them, communicate, and show them how they can easily learn or make them feel that we are there for them. So it is the usability challenges of the digital tools and wearables, and the need for strong retention and support strategies. So some pilot six, some good practices. It is the scientific foundations. We have the integrated frailty and cognitive decline prevention, digital intervention platforms and wearables, hospitals and daily care centers for the recruitment networks, participant engagement through home-based digital monitoring, and the transition that supports scalable prevention strategy for aging population. So thank you for that.
Thank you so much, Maria, for this comprehensive presentation. It is a lot of work you are implementing, and the comprehensive approach with so many older adults can be really a challenge. So you have been explaining how the adherence of older adults can be a challenge. So I would like to open the floor to discussion. Are there any questions for Maria? Yes, Leo.
Thank you, Maddalena. Thank you, Maria, for a really good both overview and a deeper dive into the work that you've been doing. I mean, I've been involved in remote monitoring for many years, and it seems to me that, you know, we're hearing the same problems. For example, the maintaining engagement with the users, particularly a group of older people that are frail and have dementia, is challenging, and that is completely understandable. I mean, and I was wondering how static or dynamic the what they're asked to do is, because one of the things that I think we've learnt is that if you've got a static app that asks the same things each day, you know, doesn't really change, means that people get bored. And you know, we're all human beings, whether we've got dementia or not. And if something doesn't change, it is very difficult to maintain their engagement. And I think you also mentioned about strong retention and support. And if that is sitting with human beings, it's unsustainable as a service, because human beings are the biggest problem in terms of their availability, and also the cost element of it. So I just sort of wondered about those. But obviously this is, you know, with this particular cohort of people, you know, traditionally with telemonitoring, people with any level of cognitive decline were actually excluded from participating in the project. So I recognise on the one hand that it's a real, you know, we have to do this learning, we have to go through this process. But I wondered, you know, in terms of my comments, how those sorts of things have been either factored in or you're thinking about for future sustainability.
Okay, thank you for your question. Firstly, I would like to answer the static part. In order for us to keep their interest alive and also to, of course, enhance adherence, all the physical activities, the app that provides the physical activity and the nutritional guidance, it has a core which is static, but the content, it's not. So the physical exercises are different each week. They are not changing all the time, so that it will be too fast for them to accumulate. All that will be for them stressing. So each week they have different a set of exercises. For 1 week they have to do specific exercises, so that is easier for them to implement. We've set some cut-offs for that. So we tell them that it is the best for them. The best interest for them is to do it 3 times a week, at least. And the next week we have a different setting. So the next week we have different setting of exercises that enhances different parts of the body, strength, flexibility. Next week something else, and that is for 18 months. So we've produced exercises that each weeks are changing, and we have different levels. So at the end of after 2 months, they have a questionnaire that the participant is filling in the app, and the app puts him into specific if they have to level up, if they are in a basic level, if they have to go in a more advanced level of the physical activity. That's not the static. Also that it is for the nutrition. The only static, it is the recording of what they are eating, keeping track of what they are eating. But we provide some information, and also we provide recipes. Recipes are many, they are different. So they can change each time and they can try new things. It has some static parts, but mostly it's something that tries to evolve and tries to keep their interest for these 6 months that they have to do the intervention.
Well, that's brilliant, Maria, and well done, because that's a huge advancement in terms of, as you rightly said, that 18-month intervention. It can be a real problem in studies like this, can't it?
The intervention lasts the intervention lasts 6 months. We follow them for 18 months. Okay.
Yes. Yeah.
About the other part, about the adherence, yes. For the time being, the adherence, it is done by people where they are monitoring how and if they have difficulties, how if they are adherent to the program. So each week we communicate with them. We maintain a strong communication in the first month in order for them to be trained to learn the app, to learn the tools, to feel comfortable using them. And then in the progress, we just keep track of what they are doing. So we're not always try to push them if they have already learned it. But yes, this is done by humans at the time being. But it is a possibility that this can be done also with the dashboard. It can be done with them in the future with some prompts to help them and motivate them to do that themselves. We just didn't want to do that in this part because we thought that having all the time an app that gives signs about do that, you forgot that, popping up, it's something that an older adult can be irritated or lose his interest. So we wanted at the first point to have it as a human contact.
Yeah, and it's important that it shouldn't be, people's experience shouldn't be entirely digital if they don't want it to be entirely digital. So I think it's entirely right, and I was really encouraged by, using my words, you're thinking about the nudging and the motivation for the future, and that at the moment is provided by humans. So really greater depth that I hope participants in the webinar have appreciated, that you've given really comprehensive answers. So thank you very much, Maria.
Okay, thank you.
Thank you, Leo. Maria, there is a question from Luke. I don't know if Luke wants to ask you the question directly, or do you prefer I read them?
Yeah, it's really quick. Hello, Maria.
Hello.
Yeah, I was just curious to know how is the user interface designed? Does it capture what the people are eating? Because that's not so easy. Is it just free text, or is there just have a pick up some things, or because that's usually a kind of data which is not so easy to capture. So how is it designed? And the second question is to maybe tell us a bit about your current dropout rate.
Okay. If I understood about the eating, how we capture what they are eating.
Yes, that's it.
About
Yeah,
okay.
because that's usually not an easy one.
It's
in order to interpret this data. So what is your recipe in order to make it meaningful?
We are trying to keep as possible for them to keep a diary. So in section where is the nutrition, we have the recipes, and we have a daily plan, so they can make their own plan of what they're going to eat in the next day or in the next week by pressing a button, the recipes we have for them, divided in categories: breakfast, lunch, a snack. Or if they decide not to do some of the recipes, there are tags like what they ate. They ate a breakfast that has yogurt or has proteins, if it is vegetable and meat. And so we can see their lifestyle and the nutritional lifestyle. And it is in behaviorals, we see that helps if you can see what you are eating.
Okay, so I understand that actually it's either they can just tell the app that they have been following the menu which has been proposed, which is fine. Either they can just then pre-select in a list, right?
Yes.
The kind of food they have been taking. Okay, thank you.
Yeah, and about
so the dropout rate.
The dropout rate. Until now, we don't have dropouts. We have people that declined to do the intervention because they thought they were a lot. But until now, we have people that are in the intervention. To mention, they are started in the intervention now. I mean, it is a couple of months, but they haven't dropped out. They are using it. Some more, some less, but they are all using it. So we will see more in the future about the dropout rate.
Thank you so much, Maria. It's really interesting. So we will have the opportunity to further in-depth information later on. So I would like now to invite, unless Conrad Regidak from MUL connected. Did Conrad connect? Okay, so
no, he's not here.
Okay, so we move on with Sotia Elina from SING. Pilot 8, monitoring and follow-up of AD patients towards improved personalized recommendations. So, Sotia, the floor is yours.
Hello, you can hear me, right?
Yes.
Great, I will start sharing my screen. Okay, can you see it in the presentation mode?
Yes.
Great. Okay, so yes, I am going to present the Pilot 8 here at the Cyprus Institute of Neurology and Genetic about multimodal monitoring in Alzheimer's disease to enable proactive personalized care. What we are doing here at SING, we have our participants. We aim to reach 150 participants from 3 different groups. The groups are Alzheimer's disease patients, people with mild cognitive impairment, and healthy age and gender matched controls. Yes, and some of the keywords about this study and also this presentation, it's clinical neuroimaging and omics data integration, multimodal dementia assessment framework, dementia care, the swallowing, basically it's swallowing about, we are going to study in more depth the swallowing, which we know it's affected, but it's not, it's rarely studied in depth, so we want to study it more, and also proactive, that will allow us to have a proactive, personalized dementia care. Now, as I've already mentioned, we know that dysphagia is common, although common, it's an under-recognized complication in Alzheimer's disease. Late detection leads to malnutrition, aspiration, pneumonia, and reduced quality of life. And unfortunately, dementia care pathways rarely monitor this function systematically. So what we need to do is have a proactive monitoring and combine clinical, biological, and neurological indicators. That will allow us to enable earlier intervention and personalized care recommendation. So to give you a more detail on what we are doing here at the SINC, first of all, we have the participants have their first visit where they sign their informed consent. We get the demographics and other we do other tests, other questionnaires, such as the mini nutritional assessment. They have a visit to the neurologist where they do the different clinical examinations, the neuropsychologist, and we also collect blood, which we're going to use for metabolomics and proteomics, as well as finding the ApoE status. Then the people come for a second visit where they visit the physiotherapist, the speech language pathologist that does different tests, different clinical tests, and also the neurophysiologist for EEG. Then they are done with SINC, and they go for external visits for brain MRI and also with the fluoroscopic swallowing assessment, the VFSS, which is an instrumental study of the swallowing. And also the clinic is in close cooperation with the bioinformatics department, who are going to do the bioinformatic analysis, the multimodal data integration for comprehensive profiling, network analysis, enhanced machine deep learning. So their aim is to do the processing and the analysis once the data are collected. Here we have the overview of the good practice. As we've already mentioned, we want to achieve a multimodal monitoring framework for Alzheimer's disease, and we want to integrate the different assessments, such as clinical, biochemical, neuropsychological assessments from the physiotherapist. And also we have the instrumental evaluations, which are the MRI, VFSS, EEG, and the multiomics biomarker analysis. This will allow us to secure a digital integration of the above for longitudinal monitoring. Here we have the core innovative elements. Firstly, we have the multiomics biomarker integration. We are collecting the blood, so we can do the biomarker analysis and see whether we can identify any links between dysphagia and cognitive decline. Here we have the dysphagia monitoring for dementia care. So we want to allow a systematic swallowing assessment to be integrated into the dementia monitoring, and see whether we can identify early swallowing dysfunctions which affect the nutrition and the safety. This will support an earlier clinical intervention and personalized recommendations. We also have co-creation for usability and engagement. This is something that it's done with older adults and healthcare professionals, where they assess videos and suggest ways of improvement, the accessibility or motivation. So that's becoming user-centered. Now, the transferable elements, we have the standardized data collection supporting longitudinal monitoring, the structured dysphagia monitoring protocols for dementia care, the multimodal assessment which combines clinical, imaging, biomarker data, and this will lead to a secure digital integration and enabling future AI-driven decision and support. Here we have the core elements. We have the multimodal assessment, multi-omics analysis, dysphagia monitoring, and finally the secure digital data system. So this is in a table. Here are some of the data requirements. We are collecting even more. These are just some examples. For example, for the clinical assessment, we have the mini-mental, the MMSC. For the swallowing assessments, there are different assessments in the clinic, such as MAN assessment of swallowing ability or E10. Then we have the EEG and MRI neuroimaging data, the blood biomarker and genetic data, and also the lifestyle and functional assessment data. Now, the technical infrastructure, first of all, in order to achieve what we are talking about, someone needs the VFSS diagnostic capabilities and trained specialists. We need the neurophysiologist to perform the EEG, and also the MRI access with specific standardized protocols. Of course, we need the bioinformatics infrastructure to do the analysis, and also the secure anonymized digital storage systems. Here it's more about our organizational model. We have here at SING a multidisciplinary clinical team with different healthcare professionals. We have the neurologists, neuropsychologists, nurses, physiotherapists, specialized speech language pathologists, which are who are specialized in dysphagia. We have the clinical researchers, which support the data collection, and also bioinformaticians who are supporting the multimodal data integration. Of course, we need the coordinating and scheduling of the clinical assessments, because we, as I've already mentioned, we are trying to minimize the visits that each participant will have to do. So we combine the appointments in order to ensure that people are not, this is not an extra burden for someone who wants to participate in this research. And we also need the community outreach and to support recruitment and awareness. And in that sense, we have already organized workshops, Dementia Awareness Day. We've also talked on radio and on TV about dementia. So we've done other things besides the pilot, running the pilot. Here it's more on the implementation process. We have the participant recruitment, first of all, which is on 3 cohorts. We've already mentioned Alzheimer's disease patients, mild cognitive impairment, people with mild cognitive impairment, and also the controls, healthy individuals who do not mention any loss of their memory. We have the baseline multimodal clinical and neurological assessments, the instrumental swallowing and neuroimaging evaluation. We have the blood sampling and omics processing, and also for some of the tests, we do this. We are going to repeat some of the measurements, so that's longitudinal. Here are the lessons learned. As Greek pilots, we've seen that we need the validated translations of assessment tools, because some of them were not already translated in Greek. So we combined our powers in terms of the common language. So we've tried to do this. We also need the VFSS and the MRI. We need these facilities in order to have this included in this research. And of course, you've seen, I've mentioned so many professionals, healthcare professionals, and also researchers from different disciplines. So that's complex, and it requires multidisciplinary coordination. And this hopefully will lead to the predictive modeling. And finally, here it's the blueprint. So first of all, we are going to see whether we can set dysphagia as a critical dementia complication, and how this can be observed early, and how it can help, how can it also be used as in combination with other biomarkers. Also, it's the technological infrastructure to allow the multimodal diagnostics and the analysis of omics, proteomics, metabolomics, the organizational model, these multidisciplinary dementia monitoring teams that we've mentioned, the participant engagement, which it's, we are doing this for the people. This is our center, this is our approach, so it's all for them. And then, of course, the transition. So hopefully this will support the personalized dementia care pathways. So that's all from me. I'm happy to take your questions.
Thank you so much. This was a rather in-depth evaluation, including morphofunctional assessment of the brain and the number of specific biomarkers like ApoE, predictive, strongly predictive. So before I ask you my burning question, I would like to leave the floor to the people participating. Are there any questions? So I want to break the ice, because this comprehensive approach, you know, we are in the middle of a paradigmatic change in service provision that focuses on the community a lot. And I think that your pilot shows very well that we have a need for high complexity hospitals and places where this kind of evaluations can be carried out. Now, my question is about sustainability, because this is going to be expensive. So in your experience, do you have an idea of which subset of patients could be evaluated in this with this approach in a third level structure? Because in my view, this is the setting is high specialty to deploy this kind of evaluations in a way that is comprehensive, and then it could be connected to other evaluations on the community. So this is a bridge between high level structure and community integrated care. So which subset of people would you recommend undergo this kind of evaluation if in the future we manage to develop a business model that makes it available for patients?
I'm not sure I entirely got the question, but I will try to answer it. And if it's,
I'll make it simple. So this kind of comprehensive assessment could not be sustainable for patients at broader as like a primary prevention. It's impossible.
Oh, you need to do everything together.
So we need to sharpen the focus in terms of setting. So where do we make this service available to people? And on the other side, who are the people who should take advantage of it? So these are two different questions. You know, if we want to use it.
So what we are doing here, it's doing this in combination. So any assessment that we are doing is combined with something else, because you have the cognition and then you have the assessment by the speech language pathologist. So the idea is that this will lead to the identification of biomarkers that will allow the better prediction. So it really depends how you can how someone can approach this subject. This is for prediction. So ideally, if it leads to better ways of predicting, that would be people, that would be everyone who is aging. So, and then what would you choose? It really depends from the biomarkers that we are going to find. For example, if we identify something that the speech language pathologist can find it early, then the speech language pathologist would be the ideal person. If it's a biomarker which it shows long before someone shows symptoms, then that would be the blood analysis. So it really depends on what we are finding.
Yeah, exactly. So I think we need to wait until you complete the study, because this way we can put in order in order the different evaluations that you carry out, and we can try to make an effort to dedicate the assessment to those who really can take advantage of it, so it's sustainable. Because in public health systems, I really doubt we can afford doing a morphofunctional evaluation of the brain plus ApoE plus blah blah blah. So we should probably try to put like them in a crescendo of assessments, correlating also to other elements.
Yes.
So thank you so much. It's really very, very interesting, and I'm eager to see what comes out of your studies.
We are all
Any,
looking forward.
yeah.
I think there is a question in the chat.
I didn't see it, sorry. How, okay, Diane Whitehouse. Diane, do you want to do the questions? Diane? Well, I guess I can read it.
Actually, a very practical. I read. I can read it. How
Yes.
easy has it been for SING to obtain volunteers, such as attendees and their carers, who would have to support them attending the myriad appointments, given the complexity of the whole study? That's a very practical question. Thank you. So the idea is that we have people. Yes. So you are concentrating on the people who would need their carers to come with them. We are asking people, and then if they are happy to come, it really depends from personalities, from the personality of the carer on that stage. So that means that, for example, we say that these are appointments that the idea is that when you participate in a study, you are helping other people for the future. But at the same time, if anything comes up from these myriad appointments, we let you know. So there is something to take. But other than that, it's volunteering, and some people are really happy to help for the sake of science. And especially when you have someone in your family that has dementia. Most of the times you are more sensitive on that subject. So actually, some people see it that way. So with that help, they might get help later with this research. So that's why I'm saying it's more on how each person approaches it. So it really depends.
Thank you so much. So thank you, and we will be waiting for your results in the future.
Thank you.
So I would like now to invite Andrea Stamate from Anna Aslan Foundation to illustrate the Pilot 9 study of frailty syndrome. Please, Andrea, the floor is yours.
Thank you. If you could share. Yeah, that's great. Thanks a lot. Okay, so today I want to share with you our work on COMFORTage Pilot 9, which is a co-created home-based digital approach to frailty management. We combine remote professional support with hybrid data capture across clinical and everyday settings. Next slide, please. At its core, Pilot 9 sits at the intersection of 6 ideas: home-based frailty prevention, digital multi-domain interventions, remote monitoring with professional support, which is enabled by wearables and smart devices, hybrid workflows, and integrated data ecosystems that ties it all together. Next slide, please. Frailty is one of the most pressing challenges in current older adult care. It significantly increases the risk of falls and hospitalizations, as well as cognitive decline, as my other colleagues have stated in their presentations as well. Yet our current response remains largely reactive and clinic-centered, when what frailty actually would demand is sustained behavior change in patients' everyday lives. There's a clear and growing need for scalable home-based prevention models. And our goal is to meet that need by supporting older adults through personalized digital frailty management. However, few existing solutions truly deliver on this, and most fall short of integrating behavioral intervention, clinical oversight, and real-world data capture into a single coherent system. That's the gap that Pilot 9 wishes to close. Next slide, please. So Pilot 9 is a 12-month personalized home-based intervention that brings together exercise, nutrition, and continuous monitoring within a single workflow delivered through tablets, smart bands, smart scales, and some strength aids. The exercise intervention itself was co-created through workshop with medical doctors and physiotherapists to design the actual exercises for older adults, and then through second workshops with older adults, where we wanted to see whether the delivery mode is appealing to them and a few other mostly visual issues. These workshops ensured that the exercises would be both clinically grounded and meaningful to the people that were going to use them. Now, before the 12-month personalized intervention, so before the full rollout, we are running a pre-pilot to validate the technology and the clinical workflow to see if these would work in real-world conditions. Next slide, please. Our target population for the main pilot are adults 65 and over with pre-frailty and or frailty, but we're trying to focus on pre-frailty more. These individuals are identified through community outreach as well as from our patient pool. Eligibility is confirmed through medical and geriatric assessment at baseline, and it's aligned with the Fried phenotype criteria, after which participants are randomly allocated to either an intervention or a control group. Next slide, please. The first core innovation is the personalization aspect. So rather than using a one-size-fits-all program, each intervention is shaped at baseline and then is continuously refined using longitudinal data. What's important to note is that we don't allow digital changes of these intervention programs. So we will take into consideration the data that we collect from participants at home, but any change in the intervention would only be decided by the medical staff at reevaluation. The intervention is delivered through tablets and digital applications, specifically Healthensia, and users use wearables and smart scales to track health indicators over time. And they use some strength training aids, such as weights and elastic bands and so on, to support their physical progress along the way. Next slide, please. The second core innovation is remote monitoring with professional oversight. Physiotherapists and geriatric specialists will stay actively involved through a clinician-facing dashboard, which would help them track adherence, functional outcomes, and risk indicators in real time. This is not passive data collection. Feedback loops feed directly back into the intervention, which will then allow us to make adjustments as participants progress. Next slide, please. A third core innovation is how the intervention was built. Like I said, end users and clinicians were involved across the design, across testing and refinement. They were not just consulted once. The videos were created with physiotherapists, and they were specifically designed for frail older or pre-frail older adults. To ensure that the people that need them can actually engage with them. Next slide, please. So beyond its immediate outcomes, Pilot 9 is designed with transferability in mind. The platform architecture is interoperable. The clinical protocol spans several domains of frailty, and the care delivery model is hybrid, which makes all three elements adaptable to different healthcare systems and contexts. Next slide, please. Each of the four core elements has transfer potential, but with different levels of effort. The digital intervention and hybrid workflows require moderate adaptation, mainly to local guidelines, staffing, and digital infrastructure. The co-created content is the most readily transferable, needing primarily cultural and linguistic adjustments. Remote monitoring carries the highest adaptation burden, given dependencies on technical infrastructure, platform interoperability, and regulatory compliance. Uh, Transferable in short, but like the four elements are transferable in short, but it's not as easy as plug and play. Next slide, please. COMFORTage brings together four streams of data, specifically our pilot, clinical and geriatric assessment, and the data that we collect at the 3 time points will be stored via REDCap. We then have continuous activity and exercise data, which is captured via wearables in the participants' homes. We also have self-reported nutritional information and periodic quality of life measures. Each stream of data has its own governance requirements, from secure device platforms integration to standardized input formats, but together they build a longitudinal picture for the participants, which is currently highly missing in how we view frailty over the course of the participants' lives. Next slide, please. Technical infrastructure. It spans over 4 components. We have the tablets for the for delivering the intervention, the smart bands and the scales that aid us in monitoring the users continuously. We have Healthencia and TET&TEM for delivering the intervention and serving users while they are at home. And we also have a clinician dashboard, which I think is integrated with the REDCap for clinical data management and transfer. Each layer is designed to work together as a single operational system. Next slide, please. Delivery relies on 3 teams working in parallel. We have the clinical team, the physiotherapists and geriatric specialists. They supervise the intervention and monitor participants' health. We have the technical team that manages the digital platforms, the data integration, and system maintenance. And then the operational team that handles the recruitment, onboarding, training, and they offer ongoing participant support. Together, they form the collaborative structure. Mic is on?
Please, can you mute? Can you mute microphones? Thank you.
Right. So together, these form the collaborative structure that keeps the intervention.
Sorry, Andrea, if you push, I think there is an animation in this slide, like in the previous one. If you click, there you go. We can read easier. Thank you.
Okay. Next slide, anyway. Oh, but I think you went a little bit ahead. Anyway, no, previous, go back. Yeah. Okay, so implementation follows 5 steps. We begin with community outreach and participant recruitment.
Tutaj mówimy o platformach za 5-6 milionów, to management.
Yeah, someone's mic is on again. This is followed by a comprehensive baseline clinical and geriatric assessment. Participants are then randomly allocated to either the intervention or control group. Those in the intervention group enter the 12-month home-based digital program with continuous monitoring, and both groups undergo follow-up assessment at month 6 and month 12. So we'll have both within comparison and between group comparison within our pilot. Next slide, please. Okay, the pre-pilot is already teaching us a great deal. Platform integration takes longer than anticipated. Manual account management does create administrative overhead that scales poorly. Among older participants, digital literacy remains a real barrier, even though when we recruit, we do try to have this as an inclusion criteria, so the level of digital competency. But this remains low in the older adult population in Romania in general. This requires active support. People call in often. We have a WhatsApp group for troubleshooting and questions, which is very active. People keep disconnecting devices and forgetting how to use different things. So it's not just good design. Unfortunately, successfully implementing a digital intervention does depend on the cohort on which we're trying to implement it on. Sustaining engagement over a 12-month intervention will genuinely be challenging, taking these issues into consideration, and not just. Obviously, these are not unexpected findings, but we're trying to see how we could comfort them early on through this pre-pilot to figure out how we can better manage them in the actual pilot. Next slide, please. Next slide, please. What makes COMFORTage a good practice case is a combination
One
of...
with the animation. There is another, again, an animation. Okay,
yeah, that's it. Thank you. No. Okay, thank you. What makes COMFORTage a good practice case is the combination of 5 elements that together form a transfer blueprint. We have a solid scientific foundation in multi-domain frailty intervention, an integrated technological ecosystem, a hybrid organizational model combining remote monitoring with clinical oversight, a co-created intervention designed for long-term engagement, and a structured implementation framework built for deployment and scale up across different settings. Next slide. Oh, and that's it. Right, so thank you so much for your attention, and I'm happy to take any questions.
Thank you so much, Andrea. So are there any questions from the audience? I don't see any hands raised. Okay, I have a question for you. You mentioned that you face the retention challenges. So patients...
Not retention. Yeah, not retention. It's just troubleshooting.
Troubleshooting.
Yeah.
And troubleshooting is referred to the digital literacy.
Yes, very much so.
So, did you ever consider, because I know you are very active also in community activities, did you ever consider integrating in the pilot the opportunity for older adults to be trained in digital health, in living labs or community activities. Would that be something that could be connected to your pilot?
That would be a very good thing to do. However, at the moment, we don't have the manpower to run this
Yeah.
in parallel. Most of the people that we have as volunteers are typically engaged in different community centers where they do receive tech training, but their level is so low that they cover the basics, right? How to, I don't know, set up an account, how to send an email.
Yeah.
As soon as you introduce a new platform, they cannot adapt to the new icons, the new features. So it's not as easy as it is for us, right? So we can easily transfer our knowledge across apps, but this is not really the case for them. So I think for older adults, it's very much a hands-on and specific training that would be needed.
Yeah, so there is a need to develop also that part, because I think that's a gap in many projects. We design this in vitro model, and then when we go to deployment, there is a need for a real integration of discipline with informatics. And this is something we are trying to learn informatics in the medical and the health field, but I don't see enough effort on the side of tech people and informatics to learn from the health science and start teaching these very simple things, support us. So we need to also change the professional profiles. But did you also find resistance from the nurses or clinicians who are involved in administering these kind of tools?
So this is very much an in-house project. So we don't have this problem. But should we outreach to other clinics, I assume this would be an issue as well. Because at the same time, even if it would be easier for them to learn how to use a different dashboard or whatnot, it would still take them time and investment, which they're rarely willing to offer.
Yeah, then we have an issue with the performances, because unless the hospital director values a lot innovation and integration of innovations and measures it in the performances like an extra bonus or whatever, they're never gonna do it, especially nurses and social personnel. So this is the real challenge for scaling up. So we are at the point where we need to consider the business models more seriously and compare them to the real organization that is running our healthcare settings.
That's an excellent point. Yeah, I couldn't agree more.
Yeah. So there is
Madalena,
one question.
yes, one question on the chat. Yes, that's it.
Yeah. So there is one question from Luke that we will do at the end to one of the previous speakers. For each of the pilots, how many people are being recruited into the trials, and how intuitive are the new apps? Are they designed to align with common apps that people use? These are two different questions from Leo.
So the apps, we're using Heltensia. So it wasn't an issue of redesigning, because it's an app that's already on the market. It's intuitive to a certain extent. It might be more intuitive to older adults in countries where technology was available earlier, but that's certainly not the case for Romania.
Yeah. Okay, so how many people did you enroll in your trial so far? I think you finished the enrollment. Did you?
We finished pre-pilot enrollment. So we had the workshops where we had 30 people in the workshops. And then we have 50 people in the pre-pilot, and we'll have 150 more in the actual 12-month pilot. But that hasn't started because we're still facing quite a few technical issues.
Yes. Okay, so thank you so much. Thank you so much, Andrea. And
So if anything, just drop me an email and I'll be happy to answer any questions that anyone might have.
thank you so much.
Thank you.
So,
Have a nice day.
so now I would like to invite from CERT, Sofia Sek-Kuli, to introduce the Pilot 12, creation of future-proof, viable and active testing environment for older adults. Thank you,
Yes,
Sofia.
good morning, also from my side. Can you see my screen?
Yes,
Now,
yes.
not in presentation mode.
Now you can see it in
Now, perfect.
presentation. Thank you very much for giving us also this potentiality. So we are also delighted to present, to share our work on our pilot, which mainly focusing on active testing living lab, in line with COMFORTage cutting-edge AI innovations. Essentially, the context of Pilot 12 is to combine highly advanced technologies such as digital twins, serious games, and virtual assistants with one critical goal, the early detection of dementia and the improvement of well-being and quality of life of older adults. Using a fully operational smart home, which is located here in Greece, in Thessaloniki, the so-called NZEB smart home, Pilot 12 aims at creating a future-proof testing and training environment that supports better cognitive and physical health. To this end, it combines innovative solutions such as digital twin technologies for personalized monitoring, serious games and immersive technologies, and AI-enabled virtual assistants. All these technologies integrated in one ecosystem are designed, developed, and implemented to detect early cognitive decline. So, as it is widely recognized, the scientific and technical integrity of its initiative, and we are also following this, let's say, policy, is anchored on the contextual background and the critical challenges it addresses. For our pilot, it is very important. It was very important to have a thorough and extensive review of the literature and identify that the main problem was the very early identification of dementia, which is not visible in clinical settings. One of the main also challenges in research is that traditional assessments for dementia rarely support continuous monitoring in daily environments. And also a key challenge and very open to research, to further research, is thoroughly understanding subjective cognitive impairment, meaning that people who report cognitive difficulties, even though standard clinical tests may not yet detect clear signs of disease. Although this group of subjective cognitive impairment is heterogeneous, some individuals may represent the earliest stage of Alzheimer, and this was a very important point in our research, in our pilot. Because these early changes are subtle and difficult to identify in clinical practice. So there is a strong need for innovative approaches combined with a realistic environment for the early detection of the disease. However, age-related factors such as digital literacy, already mentioned, lack of confidence with technology, cognitive difficulties, or fear of complex systems may reduce older adults' willingness. And this is the reason that we embedded a realistic context in our study for more precise, personalized monitoring, and also to foster a greater trust and seamless integration into the daily routine of older adults. So, what is important, the main goal of the pilot was to transform real-world enable intelligent ICT environments to support early prevention, monitoring, and personalized interventions. Shifting from the conceptual level to applied practice, Pilot 12 is based upon good and I would say operationalized practices in the specific environment of smart home living lab, designed to simulate real-life routines and healthy and active living. The approach enables advanced technologies such as serious games, AR activities, and virtual assistant with a core technology that is horizontally used in all pilots, which is the digital twin. And that it is also a virtual representative of each patient. The digital twin provides a holistic representation of each participant's physiological, cognitive, and behavioral status, enabling more personalized monitoring and intervention. By integrating both cognitive and physical intervention, we are targeting to promote the overall well-being of this specific target population. At the same time, we place emphasis on evaluating usability, acceptance, and quality of life, ensuring that the technologies that we are implementing in the real infrastructure of smart home are not only innovative, but also accessible, meaningful, and beneficial for older adults in their everyday life. This is very important for us. Why it is not going? Yes. So the target population, just as all the requirements of Pilot 12, we have selected our target groups based on specific rationale. We included three main target groups, the healthy older adults with subjective memory complaints, which this is the particular emphasis of our pilots, and individuals with mild cognitive impairment. The selection of this population is carefully justified and closely aligned to the overall research of our study, as each group represents different stages along the continuum of cognitive aging and potential dementia progression. Healthy older adults, while currently functioning independently, remain at the same time at increased risk of developing age-related memory decline. And this was the reason that we included all these categories. Concerning the core innovative elements, our main methodology is to evaluate behavioral and cognitive health of older adults in the infrastructure of NZEB Smart Home, and which is a realistic testing space. Unlike traditional clinical settings, which can feel intimidating, cutting-edge technologies are embedding into everyday routines. This means that as participants engage in standard domestic activities such as making a coffee, watching TV, or moving from room to room, our sensors and smart systems are gathering data in the background without disrupting the natural flow of their day. From a neuropsychological perspective, Pilot 12 also provides significant support for ecological evaluation, as it provides a functional smart home environment than a clinical or laboratory settings, where researchers can gain a far more realistic, accurate, and detailed understanding of how cognitive decline manifests in daily routines, behavior, and decision-making processes. The digital twin serves as a powerful tool, as already mentioned, for personalized monitoring by integrating multiple meaningful sources of information from sensors, screening tests, questionnaires, and behavioral data gathering, and also behavioral patterns. Also, mainly the policy is to provide a comprehensive approach, enabling the creation of the dynamic virtual representation of each participants, reflecting their physiological, cognitive, and daily functioning in real time. And this can be achieved by continuously updating and analyzing a set of multidimensional data. So our pilot represents a multi-component intervention tool, digitally enabled, in an ecosystem that is very robust and is used in many contexts. This is the reason that could be adaptable and could be sustainable and transferable. Serious games such as virtual supermarket, augmented reality activities, cognitive games, conversational virtual assistants, and also the integration of all these multiple digital tools within one environment provide a unified approach, not only to support early prevention, but also improving user engagement, personalization, and long-term usability. A key strength of our pilots lies in its highly transferable elements, and more specifically living lab environments for real-world testing, digital twin frameworks for personalized monitoring, serious games such as the linguistic games that have been designed on a specific rationale and gained a lot of interest from older adults, immersive technologies, and interactive and motivative experience, all integrated for the sake of cognitive and physical well-being, and integrated in a future-oriented framework that can be replicated and expanded to promote healthier aging. What the core elements are, it actually, our pilot is built upon 4 core pillars that define its operational framework. First, the Smart Home Living Lab. This serves as a real-world assessment environment, allowing us to observe a behavior of the participants in a naturalistic setting. the digital twin, this personalized monitoring and predictive modeling tool that creates a virtual representation of each individual health status, serious games and emerging immersive tools for the cognitive engagement and mental stimulation of participants. And also a horizontal guideline, the user-centered evaluation that ensures that every tool we deploy and implement meets high standards of usability and final acceptance by the end user. To effectively support personalized monitoring and early interventions, which are the two main, let's say, features of our pilot, we rely on a comprehensive range of data requirements. This includes neuropsychological assessment data, for instance, the subjective cognitive decline questionnaire, behavioral and interaction data from derived from digital tools. As an example, the digital personalized treatment monitoring model for health and behavioral change capturing, sensor and environmental data, such as the environmental data of humidity, temperature, and so on. And finally, quality of life and usability measures, such as standardized tools, the 5-level EQ 5D version questionnaire. Concerning the technical infrastructure, smart home infrastructure is equipped with sensors, serious games, AR platforms, virtual assistant technologies, and the digital twin integration platform. The technical infrastructure of our pilot is built upon an advanced overall smart home ecosystem that combines multiple innovative technologies as already highlighted in one integrated environment. And bringing all these components together, we aim to synthesize data from many sources and create an individualized, personalized, and near real-time representation of each user. However, while an optimized technical environment is very important and effective, what matters at the end of the day is the collaborative spirit and the systematic work from a team which works very close and very systematically. Also, we have a very strong connection with the community center, and we recruit our people, our participants for Alzheimer centers. For a very good reason, because these centers have a very high, let's say, provide very high technical familiarity to their participants. So we engage them for the sake of our pilots and the effectiveness of our pilots. And also, our considerations is to have a continuous internal review and rigorous monitoring of the overall work that we are doing in terms of our pilot. Concerning the implementation process, I don't know how to activate this, but okay, this is the way. It's very simple. We have our pilot follows a structure and a participant-centered approach to ensure both effectiveness and accessibility. Recruitment is conducted through community organizations. Afterwards, participants are trained to the specific technologies and engaged in the serious games that we have in our platform. We have integrated continuous monitoring frame and data collection, and also periodic reviews of users' adherence and outcomes of the work. Also, to address the operational side of the work, we must have to highlight the three significant pillars. The technical integration of our system, the digital readiness of our participants, and also the recruitment and retention challenges. First, according to the integration complexity, it is of our primary consideration to bring together diverse technologies such as the smart home, living lab, and digital twins into a single cohesive framework, which requires actually a seamless back-end coordination. Secondly, we face some challenges such as the digital literacy, as I mentioned before, with the right recruitment from the right community center, but also in cases that we have participants that they do not have the level of familiarity. We, let's say, apply some training sessions in order to foster their smooth integration. Excuse me for this, but I cannot go on. Yes, and also concerning the good practices of our pilot towards the blueprint transferability, we have the technological infrastructure, participant engagement, scientific foundation, organizational model, and transition. In particular, concerning the interoperability frameworks, we have integrated digital monitoring and remote monitoring tools, all built upon a cohesive backend. Concerning the governance and financing mechanisms, our consideration is to implement successfully these mechanisms by introducing some clear governance models, and also these mechanisms can ensure that the digital platforms are not just pilot driven, but are also embedded into the long-term structures of social and clinical services, reducing the fragmentation between these sectors. And so I would we would like to highlight that in terms of pilot 12, the first and most important guideline and principle is the user-centered evaluation model that drive participant engagement. This can be achieved by combining professional care coordination with users, and this creates a hybrid ecosystem where clinical data with community-based data are in a very good coordination and shape. And towards the final goal, which is a personalized prevention pathways that will ensure that older adults at risk of dementia will receive a continuous and mainly a holistic care experience. And this is the last slide concerning the adaptation of, as you say, interoperability frameworks, governance, collaboration. I've already said that, some information about this one. Just to say that the organizational transformation required from COMFORTage on a transfer blueprint should shift from reactive to proactive. This is a consideration from us, and the answer so far from our experience is the main principle of a person-centered management of the overall technologies implemented, the overall frameworks, and so on. So this is all from my side. Thank you very much.
Thank you so much, Sophia. So this is a different perspective, because you are basically bringing us together in a place. So all the digital solutions develop around the place where people live, but people move. So in my view, your pilot opens a new scenario that is transferring the model of the living lab, that is a place, to all the places where we live, because we are home and that can be digitalized, but we may go to the community center, we may go to the hospital, and each of these settings deserves to be a place like the Living Lab that integrates a number of digital solutions, and so that the person moving around a different setting of life can be involved in this health safety net. So I would like to open the floor to questions. Are there any questions for Sophia? Leo.
Yeah, thanks, Sophia. I think it's, and Madalena has really hit the nail on the head in terms of highlighting that what you've done within the Living Lab needs to be transferable to where people actually live their lives. And that led me, while you were taking me through us through the presentation and what you're doing, I can't help thinking that the Living Lab environment isn't that replicable of somebody living with an older person living in their own home 24/7, if they're only spending some time in the Living Lab. Because if, for example, if they've had a really poor night's sleep, or that they've had a day with lots of visitors, for example, their ability to function and engage with all the stuff in the Living Lab is going to be compromised. And I wondered how that aspect of people's lives was being nuanced within the Living Lab environment, which presumably people are not going to stay in the Living Lab 24/7 for, I don't know, a week or something. So yeah, just interested to kind of understand that. I can see that it's really helpful as a pre taking it out into the people's real home environments, but it just raised a few questions in my head.
Yes, thank you very much for your question / observation. I think it is a very good observation. Just to highlight that this smart home is a prototype, let's say, living lab, where in the context of other also projects or initiatives, we have tested. We have invited participants also to stay more time. I mean, also stay at night. So this rapid prototype living lab has also proved, let's say, the added value of a more long-term assessment. But of course, I cannot substitute the environment of the home, of the real home of its older adults. This is for sure. Also, what we are trying to, let's say, exploit from the infrastructure of this smart home is to use the realistic context, as I mentioned in my presentation, in order to capture more data about the behavior, more data about the cognitive and the psychological status of its participants, because It is very well grounded in the literature that realistic context is the answer in the early prediction of some neurodegenerative diseases. So this is the reason that we are using this very, let's say, highly equipped living lab. And all the technologies that are integrated. Of course, we have also the remote monitoring, and some of these technologies are in parallel used remotely. Let me highlight that in the platform that we have integrated with all these tools, digital tools, the virtual assistant, the digital twin, the linguistic game, the VSM, the virtual supermarket app, and so on. All these tools are of different TRL levels, which means that some of the tools that are of high TRL levels, such as the VSM, the virtual supermarket, are tested also from the older adults in their home after the visits that they have. But I haven't the time to make a detailed, let's say, sorry, apologies for this, but I haven't the time to explain thoroughly about our pilot. So we are tested partly some technologies in the living, in the real environment.